Yes, good morning to all the listeners here. So I'm going to run across, not run rather, I'm going to take you a few acronyms and stick to my timing as well. So just an example here, this is how an OCT angio looks like, and where the first two slabs are the inner retina, superficial inner retina, and the deep inner retina. You have the outer retina and the choriocapillary complex. Okay, and the B scan and the combined composite angiography image here. So, what I'm going to describe today or explain in short is about the four entities out of the eight given to me because of time constraint, cut it down to four, is DSM. So, DSM stands for dome shaped maculopathy. Something was labeled as SHRM and SHE. SHRM is subretinal hyperreflective material and SHE is subretinal hyperreflective exudate. They both are not interchangeable. SHE is a subset of SHRM that we'll come across. Non-exudative CNV and type 3 CNV Octa was given to me as a topic. We'll start with DSM. So, dome-shaped maculopathy is characterized by a forward convex, bulge of the macula that is observed in the hyalomyopic eyes, especially in the OCT. And you have to understand that you need to go to the vertical scans of this OCT. If you look at the horizontal scan, you may not be able to capture it, but a vertical scan will be able to get this forward complex bulge, which you'll be able to see. Same thing if you see here, the horizontal scans in one of the patient here does not reveal the bulge. However, there is presence of a CNV in one of the patients here and with the bulge. So, DSM or dome shaped maculopathy can be associated with subretinal fluid. It may or may not be related to CNV, right? So, one way of identifying this is the presence of a octa. Octa, in especially in the outer retinal slab, will help us identify whether presence of CNV is there, and the fluid is because of the CNV. So, development of CNV is independent of the presence of DSM. It is associated with increasing age, higher axial length, and thinning of the choroid. And this octa here helps detect CNV in the outer retinal slab. Going to the next subset, that is SHRM and SHE. So basically, SHRM includes a subset of, that is type 2 neovascularization, as we saw in the previous presentations as well. Most of the presentations had the SHRM component. It can be either subretinal fibrosis, subretinal hyperreflective exudate, acquired vitelliform lesions, or presence of just a subretinal hemorrhage. They all can be classified as SHRM. Okay, so just examples of the same here. Angiography here, OCT angio helps us identify what subset it is based on, say, intrinsic vascularity, reflection of the from the retina to the SHRM level or to the RP level. And with this, we can understand whether we are dealing with a subretinal fibrosis or dealing with uh, a neovascular component or a subretinal hyperreflective exudative material. Okay, so this is the artifacts of the OCTA helps us identify and distinguish between the different components of SHRM. Third component here is a non-exudative CNV. This here, the importance is that it is mostly seen in the fellow eyes of patients who already have AMD in the or exudative CNV in the other eye. Right. So these lesions, if identified at an earlier time, we know we can treat them better and a better prognosis for the patients can be achieved. Just one case here, patient present 2018 had a PD but no exudation, vision was good and no net which was noted on the octa. Maybe a small net was noted when you see retrospectively. Uh, Going down a year later came a diminution of vision, and we see here a small net which was there. I'm not going to details of the treatment part of the patient, and this net has enlarged over a period of time. The last component here is a type 3 CNV, that is the RAP lesion. Here, basically, clinically, it's a diagnosis where you have few hemorrhages which are seen, and this tiny intraretinal subretinal hemorrhages correlate to the OCT angio in the deep in the deep inner retinal layer. Okay, so the net present in the deep inner retinal layer reflects or explains us towards a diagnosis of a RAP lesion. Just last two slides in understanding when do you call CNV as active using Octa. When there is tangle of vessels in a well-defined shape, the classical Lassie wheel pattern seen on angio. There is anastomosis or looping of the branching of the numerous tiny capillaries. Presence of a hypointense halo. Okay, again a very important sign, and that halo, once it regresses, can also suggest that activity has gone down. So larger, more mature vessels, dead-tree appearance, and no perilesional halo points us towards an inactivity on the OCT angio for a CNV. Just the take home message quickly, dome shaped maculopathy helps differentiate the fluid which is present in OCT angio helps differentiate the fluid present in the dome shaped macropathy, whether it's related to CNV or not. Shram, various types can be identified through the various artifacts on the OCT angio. Non-exudative CNV, Octa helps us to identify it early, diagnose early, and had a better response. And type 3 CNV or the RAP lesion that is seen in the deep inner retinal slab. Thank you so much.
Thank you, Bhavin. Most importantly, for such a nice, crisp presentation, keeping to time. We have a time for one quick question. Anyone has a question? Ramesh can start getting.
Thank you.
One question that
Yeah.
till the time they swap the laptop, so what would be your treatment plan for a non-vascularized shrimp? You can start.
So a non-vascular stem, whether it's a fibrosis, is important to identify whether it's a fibrosis or it is an exudate or a vitelliform lesion there, or it can be hemorrhages, right? Clinical, this is based on the OCT, but the clinical scenario also matters, and the past history of the patient, like what Dr. Mohit showed. If you have multiple injections taken and it's
So
a
sometimes
fibrotic
it
component,
can be like there can be a regress
it
seen.
either
So
it can
follow
be
it up
observed
closely,
or true.
and Octa may help.